Kanna sir, good evening, sir. Jailal sir, good evening.
Good evening.
I think it is 8 o'clock. The other PGS also joined. So I think let me quickly call Dr. Swagata.
Good evening, Dr. Kanagavel.
Good evening, sir. Good evening, sir. Dr. Swagata is just reached home, so she'll be joining. So it is 8 o'clock. So friends, good evening, all of you. I warmly welcome Professor Anil Gwalani, who has been kind enough to accept our invitation to join as a faculty today. Dr. Anil Gwalani is from DY Patil Medical College, Pune. And we have Professor Heman Nadial, sir, Professor of Surgery at Himalayan Institute of Medical Sciences. Swagata ma'am is from AIMS Popal, will be joining shortly. Again, Gurshantha sir also is expected to join shortly. So to have two important cases, the first one is by Dr. Anup Badone. So Anup, am I spelling your name correct? You are Dr.
Yes,
Anup
sir.
Badone. Right,
Yes, sir.
right. So he is kindly contributed by Professor Guru Shantapa sir from KIMS Hubali. And we have Dr. Aditi Shankar from Madras Medical College, Chennai, kindly contributed by Dr. Kannan. And she works with Professor P.S. Shanti madam in one of the units of general surgery at Madras Medical College. So with that introduction, we will start the session for the day. The invited faculty kindly take over. Of course, our faculty will be always there to take over. So I request the candidate, Anup Badone, to kindly share your PowerPoint and start your presentation.
Yes, sir. Thank you, sir.
To share, Dr. Anup, go to the first slide. Yeah.
Yes, sir. So, good evening, everyone. Today, I'm going to present a case on mass per abdomen under the guidance of Dr. Gurushanta Pelagachin, sir, Professor and HOD, Department of Surgery, Karnataka Institute of Medical Sciences, Hubli, and myself, Dr. Anup, postgraduate student, Department of Surgery, Karnataka Institute of Medical Sciences, Hubli. So my patient is a 18-year-old female student hailing from Dharwad, presented with complaints of pain abdomen since 1 month, complaints of vomiting since 1 week, and passing of blood in stool since 2 days. Coming to history of presenting illness, patient was apparently all right 1 month back when she developed pain abdomen, sudden in onset, more in lower abdomen, colicky type of pain, initially moderate in intensity, gradually progressed in intensity since 1 week, with occasional pain-free intervals, with no aggravating or relieving factors, and with no radiation of pain. There is also associated history of vomiting since 1 week, sudden in onset after taking food, 2 to 3 episodes per day, which is non-projectile in nature, contain food particles, bilious in nature, non-blood taste, and associated with nausea. There's also history of bleeding per rectum since 2 days, associated with mucus discharge. There's history of generalized weakness since 1 month. There's also history of bilateral lower limb swelling since 1 month. And patient gives history of not passing stool since 2 days. There's no history of abdominal distension. There's no history of constipation. There's no history of fever. Coming to past history, there is history of similar complaints 2 years back, for which she was admitted in Karnataka Institute of Medical Sciences and emergency laparotomy with resection of gangrenous jejunal and ileal segments with end-to-end jejunal-ileal anastomosis was done under general anesthesia on 9th of March in 2020, done for subacute intestinal obstruction secondary to jejunal-ileal intersusception. Post-operatively, patient was asymptomatic and post-operative period was uneventful, and patient got discharged after 10 days and was asymptomatic at the time of discharge. And the HPR of the resected specimen came as feature suggestive of adenomatous polyposis with hemorrhagic infarcts. There's also similar complaint 1 month back for which she was admitted in KIMS hospital, diagnosed with intestinal obstruction secondary to jejunal intersusception with multiple small adenomatous polyposis, and she was managed conservatively and she was discharged. There's no history of any known comorbidities. Coming to family history, there's no similar complaints among the family members, and there's no history of cancer-related deaths among the family members. Menstrual history, age of menarche was 14 years. Menstrual cycles are irregular since 1 year, with a flow of 3 to 5 days or 30 to 60 days of period. Coming to personal history, she's a vegetarian by diet. Appetite is reduced since 1 week. Sleep is disturbed due to pain abdomen. Bowel and bladder habits are regular, with bleeding per rectum since 2 days. There's no history of any substance abuse. Summarizing my case, 18-year-old female, an operated case of subacute intestinal obstruction secondary to jejino-ileal intercystis with multiple small bowel polyps 2 years back, presented with pain abdomen since 1 month, vomiting since 1 week, and passing blood and stool since 2 days, with history of similar complaint 1 month back, which was managed conservatively. With this history, I would like to keep differential diagnosis. My first diagnosis would be intestinal obstruction, secondary to additions owing to her previous surgery. And my second diagnosis would be intestinal obstruction, secondary to intercystis.
Yeah, Dr. Anu,
Yes, sir.
can you go back to your slide with the past history?
Yes, sir.
Yeah.
Yes, sir.
And in the second episode of obstruction, you have written the patient had jejunal interception with multiple small adenomatous polyposis.
Yes, sir.
Yeah, and managed conservatively.
Yes, sir.
So how this diagnosis was made of multiple small adenomatous polyposis?
Sir, she had undergone CCT abdomen. They are diagnosed multiple adenomatous polyps in small bowels.
It was diagnosed on CT scan. Jejunal
done.
interception also.
Yes, sir.
Okay. Then go to your last slide, that is summary slide.
Yes, sir.
So why you kept intestinal obstruction as your first diagnosis, secondary to adhesions? There is a history of bleeding per rectum, you said.
Yes, sir. Sir, most
So
common cause
why
of
a patient? Yeah, why a patient of adhesive obstruction will have bleeding?
so since the most common cause for obstruction is due to adhesions post-operative. So my first diagnosis would be adhesions.
No.
And bleeding might be secondary due to polyps present in the
Hello.
Yes.
Yeah. Hello.
Yes, sir.
Yeah, doctor. If you think the bleeding would be due to the polyps, small bowel polyps, but it is coming in the sequelae. There is obstruction first, and then there was bleeding.
Yes, sir. Or it could be due to complication of the obstructions. There might be gangrenous changes leading to sloughing of the.
What type of bleeding you will get? It will be frank blood. Usually, you get if there is a
There will be
obstruction. It will be altered blood basically. You will not get a frank bleeding there.
Yes.
Right?
Yes.
Okay.
In the present history, you have said there is no history of constipation.
Yes, sir.
But the same way you have said there is a 2 days he has not passed stools.
Yes, sir.
Or you there is no constipation when you are saying that patient is not passing stools?
Sir, usually constipation we take it as not passing stools more than 3 days. Sir.
More than 3 days, but you have and your first surgery when you are doing, you are making a diagnosis of subacute obstruction, but
yes,
there is a gangrenous bowel. Do you
yes, sir.
gangrenous bowel is going to produce a subacute intestinal obstruction?
No, sir. It will produce acute intestinal obstruction.
Why you made a diagnosis of subacute and then you are making it as a
Sir, 2 years back, when the patient got operated on the discharge card, it was written as subacute intestinal. They diagnosed as subacute intestinal obstructions.
What is any investigation was followed at that time and he was operated?
No, sir. Later, like 1 month back, she was again admitted in KIMS and with similar complaints, sir, CCT was done, sir, and multiple adenomatous polyps were diagnosed in small bowels.
No, the patient now has some multiple polyps, you are saying, but have you looked
yes,
at the history, anything, other features which can produce by the multiple polyps?
Unless bleeding, sir.
any other features which are your history when you are eliciting on the patient, and what are the past other things you will ask when there is a multiple polyps? What are the other features you will be seeing in the patient, or what are the things you are going to look for that?
So usually the age of presentation. Some familial adenomatous polyps present early, before the age of 20 years.
This patient is already only 14 years, no?
18 years.
18 years. So that is within that limit.
Yes.
Where will you get the polyp?
Sir, in this case, sir.
No, in this case, you are saying that post-operatively, you know there is a polyp.
Yes, sir.
Can be what are the sites?
Sorry, sir. I'm not able to.
Related to that, with related to that, what are the possibility which is having on that? So,
sorry, sir. I'm not able to hear you, sir.
Look, what are history elicitation? Go ahead, sir. Go ahead. I'm traveling. My audio may not be good. You can go ahead.
Anupa, what are the common causes of interception?
Usually, interception is seen in younger age groups, sir. In older age groups, usually we see due to growth, any colonic growth, which causes colocolic interception. Or
why does it occur in younger age group?
It's usually seen in infancy, sir. Time of 6 months to 12 months, sir. Usually during weaning periods.
That is because of?
That might be because of during weaning period there will be gastroenteritis, which may inflame the cause the Peyer's patches to become edematous and cause a leading point.
What is the cause of interception in the adults?
So it might be due to a growth or a mucosal lipoma, or it can be due to polyp also.
Any congenital condition which can lead to the interception? At the age of this age, 18 years, what you are telling.
Yes, sir.
At this age, what is the common cause for that?
So probably due to polyps, sir.
Polyp is not a very common one. Some other very common disease.
It can be due to, there might be due to inflammatory polyps also.
You know any diverticulum?
Yes.
Yeah, secondary to Meckel's diverticulum can also.
Mucus is the cause for it. At this age,
Yeah.
mucus is the cause for that. Okay.
Yes.
Now, if in this patient, this history would not have been there of the interception, then what was your clinical diagnosis based only on the history?
My first diagnosis would be intestinal obstruction secondary to adhesions.
No, there is no history. You don't have any history of that. Just your clinical presentation, which is there, but you do not have any history. Can you just go to your chief complaints?
Yes.
Yeah, based on this. Pain, abdomen, vomiting, and passing blood in the stool.
Sir, I'd like to think pathology in the colons, since she's giving issue of passing blood in stools rather than melena. I would like to keep pieces
Why
of
there should be vomiting in the case of the colonic pathology?
vomiting is usually a late presentation, sir.
But one of the very important thing which you are telling, the passing blood in the stool for 2 days.
Yes.
Does that signify any pathology? Even if there is no history of interception, still then you will keep a possibility of the interception in this patient.
Yes.
Okay.
Yes.
Right. Okay, you can go ahead here.
Shall I continue with the general physical examinations?
Anup, I would, other than intercession, I would also think of ischemic bowel.
Yes, sir.
Patient had any other bleeding disorders?
No, sir. There is no history of any other bleeding disorders.
What history you asked?
If there is any hemarthrosis bleeding through the gums,
What is the reason?
joint pain.
Why do you think that is you are asking for that?
Sorry, sir.
The second, this decade, What is other any malignancy can come?
Usually, familial adenomatous polyposis usually present before the age of 15 years.
What from that? What is the lymphoid neoplasm comes? What decade?
Leukemias,
Either leukemias or your lymphoid neoplasm includes. What are the things included in the lymphoid neoplasm? You have a lymphomas, you have a
lymphomas.
plasmacytoma, leukemia. So they can also come if the patient comes at this age. One of the presentation is the ileocecal region, where they can come with a non-Hodgkin's lymphoma that can also present with the interception of the effect. And you said that it's a bleeding, but you are not qualifying that what kind of bleeding it is. Is any character in the rectum?
Sir, she tells that she's passing blood with mucus discharge, sir. And the quantity is not much.
Color?
She told it's red in color.
So you are expecting that red color or any other altered color? Why do you get an altered color when the bleeding is from below the ligament and trees?
So there might be digestion of the components of the blood cell causing it to be dark, dark tarry.
Okay, go ahead.
Yes. Coming to general physical examination, here is a 18-year-old female patient, moderately built and poorly nourished, conscious and oriented to time, place, and person. Her Karnofsky's performance status is 90. Pulse rate is 1 or 2 beats per minute, measured in right radial artery, regular in rate and rhythm with bounding pulse. Blood pressure was 110 over 70 millimeters of mercury in supine position in right arm. Respiratory rate was 20 cycles per minute. Saturation, she was maintaining 97% at over, and she was afebrile. There's a pylorus present, and there were multiple hyperpigmented macules noted in the perioral region, buccal mucosa, and hands and feet. And also platinacea was present. And these are the clinical photographs showing this. Coming to local examination on inspection.
When you are talking about a case like this with a young child, please do
Yes.
not bring in Karnofsky or the ECOG score.
Yes.
That is only typically intended for doing a malignancy or chronically debilitated individual where you are going to give an extensive therapy.
Yes.
So this general, what you are talking about the pallor, what you are talking about then other features are very important.
Yes.
So it's good you have looked in the pigmentation in the oral cavity. Anywhere area you have seen the pigmentation?
Sir, in the hands and feet, sir.
It was there.
And yes, sir. I have highlighted in the photos.
Go ahead.
Coming to local examination, on inspection, there is fullness noted in the umbilical and right lumbar regions. Umbilicus is central. Corresponding quadrants moves equally with respiration. A midline vertical scar of size 15 cross 2 centimeter is noted with scar hypertrophy. Scar of size 1 centimeter cross 1 centimeter is noted in bilateral lumbar regions. External genitalia appears normal. Other hernial orifices are intact. Renal angles are free. Left supraclavicular fossa appears normal. Coming to palpation, abdomen is soft. A vague mass of size 10 centimeter cross 5 centimeter is palpable with ill-defined borders in umbilical region on right side, extending into right lumbar and epigastric region, which is transversely mobile and forming consistency. Tenderness is present over the mass. There's no organomegaly. There's no guarding or rigidity. A midline vertical scar of size 15 cross 2 centimeters noted with scar hypertrophy. A scar of size 1 cross 1 centimeter noted in bilateral lumbar region, which is healed by primary intention. External genitalia is normal. There's no swelling or defect noted in the midline vertical scar. Other hernial orifices are intact. Renal angles are free. There's no palpable lymph nodes in left supraclavicular fossa. Coming to percussion, mass is resonant to percuss. Liver span is about 12 centimeters. On auscultation, bowels on support. On digital rectal examination, there's no skin tax or fissure or signs. Anal sphincter tone is normal. Mucosa is normal. Rectum is empty with blood-stained gloved fingers noted. Coming to systemic examination, cardiovascular system, first and second heart sound shoulder, there was no murmurs. Respiratory system, bilateral air entry was normal. There were no added sounds. central nervous system. Patient was conscious oriented and higher mental functions were normal. There was no neurological deficits. Summarizing my case, 18-year-old female, an operated case of subacute intestinal obstruction secondary to jejunal ileal interception with multiple small bowel polyps 2 years back, presented with pain abdomen since 1 month, vomiting since 1 week, and passing blood in stool since 2 days, with history of similar complaint 1 month back, managed conservatively. On examination, Peller is present with platinacea and has multiple hyperpigmented macules in the perioral region, buccal mucosa, and hands and feet. There's a tender vague mass of size 10 across 5 centimeter, which is palpable with ill-defined borders in the umbilical region, on right side extending into right lumbar region, which is transversely mobile and firm in consistency, which is resonantly percus with blood-stained glout finger noted on peer examination. With this history and examination, I would like to keep intestinal obstruction due to intersusception, probably ileocolic, secondary to Peutz-Jeghers syndrome diagnosis.
Normally, when you are expecting ileocolic, where do you expect the mass to be?
In ileocolic, usually it will be in right iliac fossa.
When there is a colic, this is going for intersusception. What is sign D dance sign?
Sign D dance is the emptiness of right iliac fossa.
For what?
A sign of one of the clinical sign of intersusception, sir, where we can feel the emptiness in the right iliac fossa.
That is a commonest presentation. So ileocolic when it is going for that. But your case, you are saying the mass is on the right side.
Yes, sir.
So how do you explain that?
Probably there might be ileal with ileocolic intersusception, sir.
That is the commonest. That is the commonest. That goes for the Sandy dance sign. It will go to the left side. The right
Yes,
side looks empty. Probably only thing you can explain, because this is a post-operative abdomen. There may be some adhesions on that. So
yes,
even the bowels are not going up, it can be there. Otherwise, normally you don't expect that to be there.
right iliac fossa.
What is the kind of lump you get in intersusception?
Sir, usually we will feel we can palpate a sausage-shaped mass around the umbilicus, sir, with convexity facing umbilicus.
Sorry, what is facing umbilicus?
With the concavity facing the umbilicus. Sir.
Why should the concavity face the umbilicus?
Due to the presence of mesenteric attachment.
But you have described your lump which is not sausage shaped and which is not having this typical concavity. And yet you are saying that it is intersusception.
Since we had previous surgery, the anatomy might be altered and there might be additions.
And your percussion shows a resonant sound.
Yes, sir. On percussion, the mass is resonant on percussion.
You get an intersusception producing a pure resonant sound?
Not pure resonance, sir. The mass will be resonant, sir, but not as the quality of the.
You can't say the degree, but when you are presenting that, you must include that. If you said that impaired resonance, you would have accepted that. But when we are saying that the mass is having a resonant sound, that is little contrary to the expectation of the intersusception to be there.
Yes, sir. There was impaired note on impaired resonance.
Just a band obstruction producing a dilated loops there.
Yes.
What made you to think that it is intersusception is the mass instead of that is dilated? Is it the only reason that bleeding per rectum is there? That is the reason, or anything else you are thinking?
Sir, there is rectum is empty, sir, and passage of blood in stools. Classic history of red currant jelly stools is there, and also there's previous history of intersusception. Usually, the recurrence is common in conservatively managed intersusception.
Yeah, but this is an operated case. Yeah, and yet you're thinking about recurrence.
Sir, she presented again second time with jejunal intersusception, sir, which is managed conservatively.
How do you what conservative management for jejunal intersusception?
Sir, actually, patient was planned for surgery, sir. Patient due symptoms got relieved and she went against medical advice.
So patient took a proper decision, I guess, because she settled down.
She again presented after 1 month with the similar complaints.
No, but that is a hindsight. At that time, they were going to operate, and it was a patient who decided not to operate. And she survived that attack.
Patient also had multiple polyps, sir, which was not addressed after first surgeries.
That is where we
Are the polyps there in the colon?
No, sir.
You have not done any colonoscopy. You have not done any investigation. How do you say there is no?
Sir, in second, when she presented on second time, sir, CCT abdomen was done, sir, which showed multiple polyps in the small bowels, jejunum and ileum, but there was no mention of colonic, and colonoscopy was not done, sir. It should have been done, sir.
Yeah, Dr. Anu, why did you say Peutz-Jeghers syndrome? What are the other causes of small bowel, multiple polyps in the small bowel?
Sir, Peutz-Jeghers syndrome, we can diagnose since their clinical criteria are matching, sir. Patient presented with the hyperpigmented lesions over the perioral region, which is classic of Peutz-Jeghers syndrome, and also there was multiple polyps in small bowels. So it matched the clinical criteria. So my first diagnosis would be Peutz-Jeghers.
So the pigmentation, definitive mucocutaneous pigmentation you found, right?
Yes, sir.
Otherwise,
only criteria which was missing is family history.
Yeah, and in which group of polyps in the small bowel are more commonly found as compared to Peutz-Jeghers? Peutz-Jeghers is a rare. It is a rare cause of polyps in small bowel. Which is more common?
Juvenile polyposis syndrome was the commoner.
Juvenile polyposis, familial adenomatous polyposis, another which is more common.
Yes, sir.
Right?
Yes, sir.
Okay. So
Now,
sir,
you are appearing for MS, or have you cleared MS?
Sir, I'm now third year postgraduate, sir.
Very good. So now, in the chapter of intussusception,
Yes, sir.
roughly, do you know like what percentage which intussusception is common or commonest?
Most commonly is ileocolic, sir. About
what percentage?
75%.
And what kind of intussusception your patient has had?
This patient, sir,
As per your records, you know what intussusception she was operated for.
she was operated for jejunal-ileal intussusception.
Yeah, so what is the percentage of that in the literature?
It is less than 1%.
It is not less than 1%, but you have a unusual case with a much less incidence, whereas more than 70-75%, they are ileocecal or ileocolic.
Yes, sir.
What is the difference between the two? Ileocecal and ileocolic.
Sorry, sir. Not sure of the differences.
When is your MS exam?
Next year, sir.
Oh, next year. So you have time to find out. Homework. Right. Okay. So we have a case of intussusception, probably recurrent. Imagine this recurring so often. In one recurrence, she was admitted and she settled conservatively. And now again, there is a possibility that you are dealing with. Any investigations have been done in the present state?
No, sir. She presented in casualty, sir. So immediate laparotomy was done, sir, and no investigation.
Oh, she's been
Colonoscopy,
operated now for the present pain.
Yes, sir. She is operated.
Oh, I thought she was operated 2 years back.
She was also operated 2 years back, sir, and now
also she was operated.
Yes, sir.
Oh, okay. Under the diagnosis of recurrent intussusception, is that
Yes,
so?
sir. Yes, sir.
Oh, okay.
What is retrograde intussusception?
So retrograde intussusception is the rare entity where we can see in patients who had undergone gastrojejunostomy, where there is retrograde intussusception.
Sometimes there is intussusception which prolapses outside the anal canal.
Yes, sir.
How will you differentiate between a prolapse of the rectum and prolapsing intussusception?
So usually on palpation, the consistency will be like cervix, and then apex, if it visualizes, might be gangrenous.
No. The question is that it is not a gangrenous part, but something is coming out per rectum. Is it a prolapse rectum or is it the intussusception coming out? I think that is what the question is. How will you differentiate clinically, not by investigation?
So clinically, when the patient exerts, when the
No, it's already prolapsed. It's already prolapsed. Exertion is not the point now.
Patient is on your examination couch and you are seeing that something has come out per annum.
and she'll give history. Patient might give history of the
Forget
mass
about history. Forget about history. On examination, we are talking about. There is a 2-inch protrusion from the anus. It's healthy in color. Mucosa is seen. Is it a prolapse rectum or is it a apex of the intussusception which has come out? That is the question.
I'm not
So
sure.
it's given you a hint of 2 inches.
Sir, the intussusception might not reach more than 2 inches, sir, since the mesentery should be long and redundant for it to.
No.
No, it's the other way. It's the other
No.
It's the other way. Any on PR, will you feel anything? Can you distinguish between
Clinical examination, that's all.
when you put your finger, how will you distinguish between them?
It's described as how we feel cervix. So similar concepts are in.
No.
It is not related to the consistency of the mass which is coming out. It is related to your PR examination that you are about to do. Okay, I'm giving you a clue.
The length of the protrusion.
That you already said. Anything else? We accepted that.
I'm not sure.
Actually, you should say when you're not sure, you should just say, I'm not sure. Don't go around saying the same thing, cervix. Okay.
There are 3 little sweet words. I don't know.
Yes.
For your information. So that examiner can go on to other questions and save the time.
So now what you are going to do is that you are going to put your finger on the outer aspect of the mass which is coming out and the anal verge which is there.
Okay.
If you are able to put your finger in between these two, it is the interception.
Okay.
If you are not able to put your finger in between the anal margin and the prolapsing mass which is there, then it is a complete prolapse of the rectum. Okay. So that is the way you can differentiate whether it is a rectal prolapse or it is a prolapsing interception.
Okay.
Can intussusception get cured spontaneously?
Yes, sir.
How?
What is the medical treatment of the interception or conservative treatment of the interception?
Sir, hydro reduction is tried, sir, with normal saline and also barium solution is tried.
So when you should not attempt the conservative treatment?
Sir, when we are suspecting complete obstruction, sir, and if there are any complications associated, like peritonitis or any perforation, we are suspecting.
So if you are
also in adults, sir, and there's no role of conservative management in adults. Sir.
Yeah, Anup, why there is no role of conservative management in adults?
Sir, usually it is secondary to mass or any polyp or lipoma,
Yes.
subacute lipoma.
Yeah, right. So you have to go for an operative intervention to identify the exact cause, because it could be malignancy. Yeah.
Yes.
If there would not have been mass in this case, palpable mass, right?
Yes.
And you have a history that he had small bowel polyps. So how would have investigated this case?
Probably colonoscopy had been useful, sir.
Yeah, you could have got in the colonoscopy, adenomatous polyposis syndrome, few other syndromes also that are the causes. But if there are no polyps in the large bowel, then
we can go for an upper GI endoscopy, sir. We can see any polyps in stomach.
no, we are talking small bowel polyps.
Sir, CCT abdomen would pick up intraluminal polyps.
which is a better investigation than the CECT abdomen for detecting polyps in the small bowel or nodular lesions in the small bowel?
I don't know.
So you think CT scan is the best investigation to diagnose small bowel polyps?
It's not the best investigation, sir.
Then which is the best investigation? Better investigation than simple CT scan?
Well, capsule endoscopy can be done.
Yeah. Video capsule endoscopy is a better investigation. It has much more sensitivity and specificity than the CT. Or if you want to improvise CT, what could be that? CT enterography, right? CT or MRI enterography have more sensitivity than the plain CT. Plain CT has around the sensitivity of, what is the sensitivity of plain CT in detecting the small bowel polyps?
It is less than
How
60.
much is it? It's around 70 to 80% in expert hands. But for the CT or MRI enterography, it is around
80 to
around
90.
90 to 97% have been reported. What is the difference between CT enterography and CT enteroclysis?
So in enteroclysis, we give a contrast from the proximal end and then study with the X-ray, multiple X-rays.
Yeah. CT can also be taken. CT enteroclysis, where you take the CT pictures after. And what is CT enterography?
I'm not sure about CT enterography.
In CT enterography, you give the contrast through the parrectal region, not orally you give. And CT enterography is more easily accepted by the patient. It causes less discomfort to the patient as compared to CT enteroclysis if there is signs or symptoms of obstruction. Okay. Otherwise, video capsule endoscopy is another better option for the diagnosis of the small bowel polyps.
Yes.
Okay. What are the other benign lesions of the small bowel which can have presentation like this? And they are more common than the polyps of the small bowel. Or the other question is,
Sir, submucosal
what is the incidence of tumors in the small bowel when you compare it with whole GI tract?
It is usually less, sir. So rarely we see tumors of the small bowel presenting as mass.
How much? What is the incidence?
I'm not sure about the.
It's very interesting to see that though the small bowel comprises 90% of the mucosal surface area of the GI tract, but the incidence of neoplasia in small bowel is
very less.
Very less. What is the percentage?
Not sure about the percentage.
It's around 3%. The maximum series which I have shown, it is only 3% of the GI tract malignancy, though it has 90% of the mucosal surface area of the GI tract. So what are the other benign lesions which are more common than the malignant lesions?
Might be secondary due to Meckel's diverticulums.
Yes?
Secondary due to Meckel's diverticulums.
That is a congenital, so that is a separate issue. We are talking of polyps, and here you had the multiple polyps. If there would be a single polyp, which is one of the most common small bowel polyp, which can lead to interception.
So juvenile polyposis syndrome is another entity.
No, it's not. It's a lipoma.
Submucosal.
All the small bowel polyps. Small bowel lipoma contributes to around 2.5 to around up to 15% of the small bowel non-malignant tumors. Right? What are the other small bowel lesions?
Might be secondary due to purpura also, intestinal.
Yeah, hemangiomas. Right.
Yes.
Hemangiomas, neurofibromas. They are the other benign lesions which are responsible for the interception as compared to malignant lesions of the small bowel, which incidence is very less as compared to that.
Okay. Sorry.
Yes. Yes, sir.
This patient has had a recurrent interception.
Yes.
So what will you do to prevent a further interception? What steps will you take now? You
Sir,
operated, everything's done.
sir, we would like to do an colonoscopy, and if there are any large polyps, if we could remove them.
How large polyps? What do you mean by now?
More than 2 centimeter polyps measuring more than 2 centimeter are more susceptible to cause interception. So endoscopic snaring, if it's possible, you can do and remove the polyps. And if multiple polyps are there where we can't do snaring, then resection of the segment of the bowel can be done.
Okay. So you said it's a Peutz-Jeghers syndrome. So how will you follow up this patient of a Peutz-Jeghers syndrome?
So follow-up, usually we ask to get CCT abdomen every 2 years.
No. Is she susceptible to certain malignancies? Because
Yes,
this is a hematoma.
Yes, sir. She's susceptible. Yes, sir.
Which malignancies now?
The percentage of malignancy in Peutz-Jeghers syndrome unless you do a surveillance?
Ma'am, by the age of 40 years, around 85%
90% they go.
So even though they are hematomas, they have a very high risk for malignancy, right?
Yeah, in a small bowel especially.
And what about
That's why surveillance is necessary, no?
Yes, ma'am. Colorectal cancer is a possibility, ma'am. It's a risk factor, and breast and thyroid.
No.
Other malignancies.
Sir, they're more susceptible for breast cancer, sir,
and
peritoneal and endometrial cancer.
And
endometrial, ovarian, and cervical cancer.
No.
Breast. Yes.
Pancreatic and
yes,
pancreatic testicular.
Yes.
Right.
Pancreas, testis, cervix, breast, colon, stomach, all intestinal. They are more prone for. That's why Peutz-Jeghers syndrome is important.
What is the incidence of Peutz-Jeghers? What's the incidence of Peutz-Jeghers?
Sir, it is the incidence of Peutz-Jeghers is 1 in 20 to 30,000 births.
1 into 25,000. It's very, very rare.
Yes.
Right. So I don't know. So how will you confirm it's Peutz-Jeghers?
Sir, on histology, we'll find a hematomatous polyps, and clinically there.
What is a hematoma? What's a hematoma?
Sir, hematoma is a disordered differentiation during embryonic growth, which causes disrupted representation of normal tissues.
Yeah, okay. So normal tissue which is all shuffled up. In Bailey, there's a very typical description of it. The literal meaning of hematoma. That when you throw a spear, it misses the target. This was in Old Bailey. Well, this was the description there, okay?
And Dr. Anup, how many % of the patients with Peutz-Jeghers syndrome will have small bowel polyps, hematomatous polyps?
About 85% of them have the...
Right, good. 85 to 100% of the patient may have small bowel polyps. And what is the incidence? In which part they are maximum? When you compare it for jejunum, ileum, or duodenum?
In Peutz-Jeghers, jejunum is most commonly involved.
Jejunum followed by?
Ileum and then colon.
Ileum and then duodenum. If we talk of the small bowel, yes, good.
So how will you do the surveillance?
Ma'am, surveillance, we'll do colonoscopy every year, ma'am, and breast screening from the age of 25 every year, ma'am. And also pap smear annually, ma'am. And pancreatic protocol CT every 2 years, ma'am.
Will you don't want to do the upper GI endoscopy also? Because stomach is also there.
Upper GI endoscopy every year, ma'am, annually.
And which polyps you will remove? When you will intervene?
Sir, if the polyp size is more than 2 centimeter and it is pedunculated, we can go for endoscopic snaring.
No. Which polyps have more chances of becoming malignant?
So sessile polyps have the
polyps.
Yes.
Current recommendation says more than 0.5 to 1 centimeter, then you should go for its removal. Otherwise, you can wait and watch. And for small bowel polyps, how you will do the surveillance?
CT with enterography. best.
Yeah, CT angiography or video capsule endoscopy is the. What are screen relevant neoplasms? Screen relevant neoplasm when you talk of polyps in the GI tract. So the polyps which are larger than 1 centimeter in size, which are dysplastic and which are villous in histopathology, right? So those polyps, they should be followed, and they are known as screen relevant neoplasm because they have a higher incidence of developing malignancy later on. Right.
Now, this patient you have diagnosed as Peutz-Jeghers syndrome. So, how there is no family history. Okay.
There's no family history.
So, how will you once you are diagnosed with histopathology? What else would you want to like to look for? How to diagnose more important, and what is the genetic counseling you will like to advise?
Since it is autosomal dominant, ma'am, there's chance of the next generation also having the disease, ma'am, and also we'd like to screen her parents.
And siblings also. So, which gene is responsible?
STK11 gene is responsible.
STK11 and?
I'm not sure, I just know one.
Okay. So, have you asked how many siblings are they having? Because
Yes,
family is not there, you said, no?
Yes, ma'am.
So have you
There
counseled?
are 4 siblings, ma'am. Yes, ma'am.
Okay.
There's no any similar complaint, ma'am, but they have not been screened, ma'am.
They have not been screened.
Yes, ma'am.
So, because these are very genetic studies we are not doing because it is so costly, but at least we can counsel because it is an autosomal dominant.
Yes.
So what surgery she has undergone with the present episode? You said she's already operated.
Yes, sir. Sir, she has undergone laparotomy with gangrenous ileal segment resections. She had ileocolic interception, sir, and ileo-ileal and ileocolic interception. And the on table, the surgeon was able to reduce the bubble, sir, and only gangrenous segment of the ileum was noted. It was resected, and IC junction was normal, sir, and along with that, appendicectomy was done, sir. And there's have the clinical photographs. This was intraoperative photographs.
No. So the ileocolic interception got reduced.
Yes, sir.
And the ileo-ileal could not be reduced. Is that what you're trying to say?
No, sir. The bubble was reduced completely, sir.
Completely reduced.
Yes, sir. And only the ileal segment was gangrenous. The ascending colon was normal, sir, and IC junction was also normal, sir. Appendix was inflamed, sir, and edematous. So also they did appendicectomy.
Usually patients don't have double pathology. I mean, he can't have appendicitis. She can't have appendicitis as well as interception. So probably what was seen on the appendix was the external effect, effect of the disease. Anyway, appendicectomy was done is okay, that's the thing. But the entire interception got reduced.
Yes, sir.
Is that what you're trying to say?
Yes, sir.
As a MS question, how do you reduce interception? If
Sir,
you are the operating surgeon.
Yes, sir. Sir,
How
usually
will you reduce?
we're using hot packs, sir.
Hot packs won't reduce it
Milking of
automatically. You have to do something, no?
Milking of the bowel is done gently, sir.
How is it done? There's a definite method.
Named after someone.
Sir has asked a very specific question. How you will reduce the interception? Very important.
Sir,
because the one segment is inside the other segment, you will gently pull it, or what you will do?
Is it
or gently push it? What do you do?
Yeah. You will push from the distal to the proximal, or you will pull from the proximal side?
Or is it a Cope's method of reduction?
Whichever method it may be, or what is your method? I know Cope's method is a correct answer, but what is that method? We want to know that. That's an absolutely right answer. The method is known as Popes. Okay, what exactly is Popes method?
Sir, we gently try to milk the bowel. We'll pull the we'll push the overlying bowel distally.
How can you push overlying bowel? You have to push inside bowel. No? How can you push outside bowel? And what is Popes method in detail?
Initially, we'll try to reduce the bowels.
Yeah, the $1 million question. That's what we are asking for. How do you reduce it? How do you reduce it?
So
We are watching you.
Sir, we'll gently pull the bowel which has gone inside the adjacent bowel, sir. And
what are the parts
possible.
of intussusception?
Sir, intersusceptions and intersusceptums.
And there is apex and there is neck.
Yes.
We follow. So now you can use those terms and tell us.
Sir, intersusceptum is gently.
Are you pulling out the intersusceptum, or what are you doing?
Sir, we'll stabilize the intersusception, sir, and gently pull the intersusceptum proximally.
That is wrong, Vita. That is wrong. When you pull, you can cause more damage. The correct method is you feel the apex in the intersusception and using your thumb and multiple fingers gently push it. And when it is being pushed, some part is coming out from the neck and there are some flimsy adhesions. So with your little finger or something, very gently, you can break those adhesions and allow more part to come out. That's the Popes method. So you keep on pushing, never pull, never pull. Push, free the adhesions. And as it has happened in this case, the surgeon could successfully reduce the entire content. So that's very good news. The entire content got reduced. But after the content got reduced, you are saying that there was a segment of ileum which was gangrenous. Is that so?
Yes, sir. It was the segment of ileum was resected and ileal.
No. I'm trying to understand which segment of ileum became gangrenous.
Terminal ileum.
Was it the apex? No, as far as the intersusception is concerned.
Which part undergoes gangrene first?
Which is more dangerous, ileocecal or ileocolic intersusception?
Sir,
this finding gives me the clue that what type of intersusception it was.
Ileocolic is more dangerous.
I think what has happened is a ileocecal intersusception, or the ileocolic, as you're saying. Yeah. So that's why the terminal part of ileum has become gangrenous, and that was resected along with appendicectomy.
Yes, sir.
So she's undergone 2 operations for intersusception.
Yes.
2 years back and now.
No.
Do you think she'll develop a recurrence again?
Since we are not addressed the polyps, she might.
As a concerned relative, I'm asking you, will she develop a recurrence again?
Yes, sir. She might develop recurrence.
Oh. That's bad news, isn't it? How do you prevent recurrence?
Sir, we'll address.
I think that is the reason. The surgeon decided to do appendicectomy. There's a lot of wisdom in that.
Sir, we'll address the remaining polyps in the small bowel. We can do also. We should do colonoscopy for this patient to look for any colonic polyps.
But there were no colonic polyps that we have already investigated. There are no colonic polyps.
Colonoscopy was not done for these patients.
But as far as CT scan is concerned, there are no polyps. If the CT could pick up polyps in the small bowel, I'm sure they would have picked up in the large bowel as well. Because that was a very sensitive CT scan, nicely done, because it picked up.
Yes.
Good, yeah. Great. it is a rare thing that can happen, but it is described in the literature that sometimes the interception, the interseptum gets dissociated completely. By nature, the two ends of the bowel already develop anastomosis spontaneously, and the part gets expelled out per annum. So, I mean, I'm just throwing a light on that something coming out, the apex coming out from the interception. Very rarely that interseptum gets thrown out, and theoretically patient is cured of that. It doesn't happen. Good, yeah. Nice presentation.
Thank you, sir.
Yeah, Kanagavan sir, can we proceed for the next case? It's a good presentation, I think. Hello, Dr. Aditi, you can start, I think, if other senior
Okay.
teachers also
Yes.
Okay, sir. Okay, sir. I will proceed, sir.
allow for the next case. Yeah,
Just give me a minute, sir.
please share your slide, please.
I need Dr. Anup to stop sharing
Yes, sir.
this.
Yes, sir. I'll stop sharing. Thank you. Thank you, everyone. Sir.
Yeah, thank you. Good,
All the best,
good
beta.
presentation.
Thank you, sir.
All the
Okay,
best.
okay.
Yeah,
Thank you, sir.
Good presentation. Very good presentation.
yeah.
Thank you, ma'am.
Good evening to all the esteemed faculty assembled in this call. Myself is Dr. Aditi, member of IGS, final year postgraduate student in MMC Chennai. Under the guidance of Professor R. Kannan, my HOD, and my head of the unit, Professor P.S. Shanti. I'm going to present the case of carcinoma breast. 52-year-old female, Mrs. X, a homemaker by occupation, presents to us with the chief complaints of a lump in the right breast since the last 2 months. She was apparently asymptomatic 2 months ago, and she instantly noticed a lump in the right breast, which was initially 1 cross 2 centimeter in size according to the patient, and rapidly increased to the present size of about 4 cross 3 centimeter. It was not associated with pain or mastalgia. She had no complaints of nipple discharge or retraction. She had no complaints of lump in the opposite breast or the axilla on either side, and no complaints of ulceration or redness of the skin over the breast or of the lump. There were no history of trauma, of fever, of swelling of the right upper limb or a tingling sensation, no history of dyspnea or hemoptysis, no history of yellowish discoloration of skin or eyes, no history of recent lower backache or long bone pains, no history of headache and seizures, and no history of weight loss or loss of appetite. History of comorbid illnesses. The patient is a known diabetic since the last 5 years on tablet metformin OD. She's also a known hypertensive since the last 5 years on tablet amlodipine. She's not got any other comorbid conditions. Her past history, she has underwent pubertal sterilization 22 years ago. There were no history of blood transfusions or drug allergies, no history of oral contraceptive use, and no history of radiation exposure, especially to the chest. Following to menstrual history, she attained menarche at 15 years of age. Her last menstrual cycle was on 4th of this month. She's had regular cycles every 30 days with bleeding for 3 days, and no history of dysmenorrhea or menorrhagia. Her obstetric history, she's a para 2 life 2 with all normal vaginal deliveries. Her first childbirth was at age of 28 years and the last childbirth was at age of 30 years. The first child is a female, 24 years old presently, and has been breastfed for 2 years of age. The second child is a male, 22 years old, and breastfed for 2 years. Family history, her own elder sister has had a history of right-sided CA breast, which occurred at the same age as her, and she was managed with surgery 5 years ago, and she's alive and healthy at the moment. Personal history, she consumes a mixed diet. There's no history of
ये जो कोरिएंडर वाला बनाते हो, कोरिएंडर का क्या होता है?
normal bowel and bladder
मजीतो क्या होता है?
alcohol or tobacco.
मजीतो.
My history, 52-year-old menstruating female presented with a painless progressive lump in the right breast since the last 2 months with no complaints of nipple discharge or retraction. She's a known diabetic and hypertensive on treatment, and she also has a first-degree relative with carcinoma breast. May I proceed with examination, sir?
Please summarize your history first, just history part.
The summary of my history, a 52-year-old menstruating female presented with a progressive planeless lump in the right breast since the last 2 months with no complaints of nipple discharge or retraction. It's a known diabetic and hypertensive on treatment and also relative with carcinoma breast.
Okay, so what is your provisional diagnosis from this history part?
The provisional diagnosis is a right carcinoma breast.
Right carcinoma breast. Why?
Firstly, it is a painless lump that has developed over the last 2 months that the patient has incidentally noticed. She has gotten first degree relative with a carcinoma breast.
So the most important point is having a first degree relative, one thing, and second is the breast lump in the age of 50. Otherwise, what is the age group for benign lumps in females?
Benign lumps are usually occurring before the age of 30, sir.
Yeah, so that is the painless. Most of the fibroadenomas, fibrocystic breast disease lumps are also painless. Most of the time. So
yes,
here you have a first thing is the age at which it is appearing, and second is a family history. First degree relative having carcinoma breast. Okay, proceed with your examination.
General examination. The patient was examined after obtaining consent in an adequately lit room in sitting position initially with exposure down to the waist. The patient is conscious and oriented. She is well built and nourished. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Blood pressure was 130 over 80 in the right arm and sitting position. Pulse rate was 78 beats per minute, regular rhythm, normal in character and volume. The saturation was 98% maintained in room air. Now moving on to the examination of the breast. On inspection, a bilateral pendulous breast noted with elevation of the right nipple compared to the left. There was no redness of skin or nipple discharge. Fullness was noted in the right breast in the upper and inner quadrant in close proximity to the midline. A nipple areolar complex of the right breast itself appears to be normal. There are no skin changes visible. The supraclavicular fossa appears free, and the arms and thorax appear normal. In this image, we can appreciate that the right-sided nipple areolar complex is slightly elevated as compared to the left, hence constituting asymmetry of the breast. Upon elevation of the arms, there was no skin puckering, dimpling, or distortion that was noted or enhanced. The inframammary fold appears to be free, and the axilla appears to be free. Upon bending forward, both the breasts fall freely with no obvious skin changes or nipple retraction. Coming to palpation, the patient was examined in a combination of sitting, semi-recumbent, and supine position as and when required. The left breast, axilla, and supraclavicular fossa were found to be unremarkable. Coming to the right breast, there was no warmth or tenderness. A lump of 4 × 3 centimeter, which is ovoid in shape, was noted in the right breast in the upper and inner quadrant between 1 and 2 o'clock positions, parasternally. The margins were irregular, the surface was nodular, hard in consistency. There was no fixity to the skin or pudgy-orange appearance. The lump moves along with the breast tissue and sticks to the pectoralis muscle. I'm sorry, sir, it's a muscle, not a fascia. And there was no fixity to the chest wall. This demonstrates the tautness of the pectoralis muscle as well as the examination of the movement of the lump after making the pectoralis taut. There was no nipple discharge noted, and no nodes were palpable in the ipsilateral axilla or the supraclavicular fossa. And upon percussion, no dull note was noted in percussion of the 2nd to 6th intercostal spaces parasternally. Now, moving on to the systemic examination, the abdomen was soft. There was no mass palpable and no organomegaly, specifically no pelvic mass was palpable. There was no evidence of free fluid. The perrectal examination was unremarkable, and pervaginal examination was also unremarkable. Cardiovascular and respiratory system were within normal limits. CNS, there was no focal neurological deficit. Back, spine, and musculoskeletal system were all normal. Now, summarizing my case, 52-year-old menstruating female presented with a painless progressive lump in the right breast in the upper and inner quadrant for the last 2 months, and she had a family history of CA breast. On examination, she was found to have a lump of 4 × 3 centimeter in the right breast in the upper and inner quadrant that was hard in consistency and fixed to the underlying pectoralis muscle, but not fixed to the skin. There was no evidence of involvement of the axilla, the contralateral breast, or the contralateral axilla, and there was no evidence of systemic metastasis. Clinical staging will be a T2N0M0 stage 2A disease.
Okay. When you raise the arm, what do you look for?
Sir, firstly, we look for any tethering that will become more obvious if we raise the arms. Secondly, we have to examine the intramammary fold if there are any
No, you've missed something. That's why I'm asking you. That you've said intramammary, I've seen that. I've heard it.
So the tethering of the skin will become
Tethering
more,
is not. What is tethering?
Tethering is present due to the involvement of the Cooper's ligaments. Sir.
So you have to look for the movement of the nipple on each side. When you raise the arm, that is important.
Yes, sir.
What will happen to the side which has got a lump?
The nipple will be further elevated, sir.
So there'll be will there be a larger movement or a less movement?
The movement will be restricted, sir.
No, it will be larger. It will be more be pulled, right?
Will be pulled along with the lump.
Pulled a lump, right?
Yes, sir.
So in which condition it will not be pulled along with the lump? It will be displacing it.
In large benign conditions.
Yes, in benign. No, in benign lumps.
In benign.
Okay. So you missed that. That's why I asked.
Okay, sir.
How do you palpate breast?
The breast is palpated in a radial fashion as well as in a circular fashion, sir.
No. How do you palpate breast? You are MS
With
going.
the
When are you
palmar
appearing
surface
for
of
your
the
exam? When are
Breast
you
is palpated.
appearing for your MS exam?
Yes, sir. Firstly, the position of the patient.
No.
Sir.
When are you appearing for your MS exam?
Oh, when, sir, next year, sir.
Next year, 1 year. Okay. Now tell me, because you can be asked to demonstrate how you palpate breast. So
We'll start with the
how will
position of
you-
the patient, sir.
what is the position of the patient?
Patient can be examined in multiple positions. Firstly, in sitting position with arms by the side, sir.
No.
Then-
I'm talking about palpation. For palpation, what position you give?
Which is the
Palpation
best
is
position?
performed best in a semi-recumbent position, sir.
Why?
Patient
Why
is
do you-
supine.
The lump is felt best when it's falling on the chest wall, sir.
It spreads over the chest wall, then only you can palpate it properly. Yes.
So patient is supine, and some ladies' anatomy is such that you may put a small pillow or a folded bed sheet under the scapula of that
Yes.
side to steady the breast on the pectoral region. So the position of the patient during palpation is supine. As a courtesy, do not palpate lump in breast with the patient in sitting position.
Yes, sir.
Okay, it is supine. Now with supine position, what is the technique of palpation?
The breast is always palpated. The lumps are best felt with the palmar surface of the fingers, sir.
First palpate the normal breast.
Yes, sir.
First palpate the normal breast.
Yes.
Now coming to the diseased breast, how do you palpate? What is the description given when you're putting your hand? What is it called? Which part of your hand are you touching?
The palmar surface of the fingers, sir.
It is not called palmar surface, beta. See, palmar surface is this. You don't palpate like this. This would be, nobody does it. I'm sure you also don't do it. It's not the palmar surface. It is this. And this is called the flat of the hand. So use the correct words in the exam.
Okay.
You will be doing that, I'm sure. You are a resident. You will be palpating like this, but you don't call it as the palmar surface. You call it the flat of the hand. So palpate the normal breast first. Palpation of the breast is the patient in supine position, and palpate with the flat of the hand.
Okay, sir.
Now, what is the characteristic? What is the importance of this palpation with the flat of the hand? There are some lumps which are palpable with the flat of the hand, and some which are not palpable with the flat of the hand.
So usually in a fibroadenosis, the lumps will not be palpable with the flat of the hand, sir.
Yes, so any lump,
fingers.
very good, very good. So any lump which is palpable with the flat of the hand is a very significant lump.
Yes, sir.
Whereas the lumps of fibroadenosis are not palpable with the flat of the hand. So how are they palpable?
They have to be palpated.
And what is that breast
fingers,
described
sir.
as? Yes, they are appreciated with the flexion of the fingers.
Yes.
So that is a very important clinical finding. Okay, so that breast is called a knotty breast, KNOTTY, multiple granules, multiple lumps, which are felt with the fingers, but not with the flat of the hand.
Yes. From where do you
that's a
start
very
your
important thing.
examination? In the breast, how do you start your examination with the flat?
Family make this flight memorable experience for all of us.
The palpation will be started from the nipple areolar complex, going circumferentially to the axillary
I'll talk to you.
And what are the other methods of palpation apart from this?
Radial palpation can be done, ma'am, starting from the nipple areolar complex, radially in all directions of the breast, ma'am. And also in an S fashion, starting from the axilla, going towards, in an S direction, towards the end of the breast.
How do you palpate the nipple areola?
The flat of the hand, ma'am.
Nipple areola, how will you palpate?
The nipple can be palpated between two fingers, ma'am.
So where will be your fingers?
The index finger will be on the superior portion, and the thumb will be on the inferior portion of the nipple.
You will have the areola and nipple full under your two fingers.
Yes, ma'am.
First, on two perpendicular direction. You have already palpated with the flat. Then you have to raise the nipple and see whether something is palpable in the retroareolar, and by pressing from the side when there is any nipple discharge.
Yes, ma'am.
Okay. So now in this patient, it was the family history is positive. So how do you differentiate, or what is a familial breast cancer and what is a hereditary breast cancer?
Hereditary breast cancers are ones which have genetic component predisposition involved. Now, familial breast cancer is a clustering of cancer in a family which is more than can be explained by normal chance.
And first degree relative.
First degree relatives, which is also having a genetic component.
You have said that the lump is attached to the underlying pectoral fascia. So
yes,
how did you see that it was? You had told that you had fixed the muscle. So
yes,
how did you find that after fixing the muscle? What was the movement? How do you came to the diagnosis that it was fixed to the underlying pectoral fascia?
So since this lump is more in the upper and inner quadrant, the direction of the pectoralis major fibers will be more horizontally oriented there. So initially, before we make the muscle taut, we have to move the lump in perpendicular directions. That is along the fibers as well as perpendicular to the direction of the fibers. So after the muscle is made taut, we again perform the same movement, and we note that there is a restriction of mobility in both directions.
So
is the lump attached to the pectoralis major muscle? Because you are saying it is attached to the pectoral fascia. That
sorry,
is what
sir,
madam is
I
asking.
clarified that, sir. It was attached to the pectoralis muscle, sir, not to the fascia, sir.
Oh. Okay. Why do you say clinically it is, if we did not have history of the family?
Yes, sir.
if we for some time do not think about the family history, then what would be your diagnosis?
We can still
Forget
my
about the
first
family
diagnosis-
history.
Still
Forget
my
about the
first
family.
diagnosis will be a carcinoma breast, sir, considering the age of the patient, sir.
That is one thing is age. Any other
Yes, sir.
reason to suspect carcinoma in your patient? What are the 3 cardinal signs of carcinoma breast? 3 cardinal signs, because even if one of them is there, clinical diagnosis is carcinoma. Mention those 3 cardinal signs.
Lump in the breast, sir.
Sorry?
Lump in the breast, sir.
No. After the lump, what are the signs which are the clinchers? Clinical clinchers.
Nipple retraction, sir.
Nipple retraction. Very good. Your patient is not having.
She's not having it,
Yeah.
sir.
So second,
Nipple discharge, sir.
you have already mentioned it. No, it has nothing to do with discharge. This is examination finding. Don't get nervous. You're doing well. You have already mentioned it. There is no
Skin
nipple
involvement.
retraction. Then
Skin
what is
involvement, sir.
skin involvement in the sense?
Form of
No
steroid
dimpling. No
or
dimpling.
pathology.
Dimpling of the skin and no poddy orange.
Radiology, sir.
No poddy orange. Okay.
Yes, sir.
Now, these 3 cardinal signs, if even any one of them was there, my diagnosis would be carcinoma.
Carcinoma.
But all these 3 are missing. Are you
Yes,
getting
sir.
me? That's why I
Yes,
asked you
sir,
this
I
question.
understand. Yes, sir.
52-year-old lady, forget about her sister having carcinoma.
Yes, sir.
She's come with a lump in the breast. And these 3 features are missing. And yet you give diagnosis of carcinoma. Why is my question. Though your diagnosis is correct and I know the reason why I would give it.
This is based on just history, sir, or
On
with
this
my
patient,
examination?
on this
With your examination.
So with my examination, the consistency of the lump, it's a hard lump,
Very
sir.
good. Yes, it's a hard lump.
And
It's a hard lump, right?
yes, sir.
And fixed to the
Absolutely.
And
underlying.
fixed to the underlying muscle, sir.
How do you classify lumps in the breast? Clinical classification of lumps in the breast.
Benign and malignant lumps.
That is one classification. There's another beautiful classification, which I'm sure all MS going students should know.
Sure, sir.
Lumps with signs of acute inflammation.
Okay, sir.
Second group, most important. Small,
Yes.
firm to hard lumps. That's the biggest group.
Okay, sir.
Then fungating lumps, massive lumps, lumps under nipple and areola, and cystic lumps.
Okay, sir.
If you know this classification, you have an eagle's eye view.
Yes, sir.
Do you follow?
Yes,
So
sir. And
any lump in breast is always a suspicion. When there is a murder, suspect everybody. So the best way not to miss out a carcinoma is suspect carcinoma in all cases and then rule it out.
yes, sir.
So I would defend my answer in this way.
Yes,
The
sir.
lump is hard, and of course, any lump in breast is to be a suspicious one, even though those 3 cardinal signs are absent.
Yes, sir.
Yeah. Now, madam, take over.
So your diagnosis is T2N0 M0 stage 2A. So what will be your clinical stage? What will you call this as?
Early breast carcinoma, sir.
Early breast carcinoma. So now how do you want to proceed?
I want to do a radiological investigation first, ma'am. I
For
want to
all
do an
breast lump, what is the terminology we use for diagnosis?
not getting the question, ma'am.
For all breast lump, what
The
is the
triple assessment.
terminology we use for diagnosis? There are 3 modalities.
Triple assessment of
Triple assessment, that should be the answer. Okay, so now in triple assessment, clinical breast examination you have done.
Yes, ma'am.
So it is a hard fixed lump T2N0 M0. Okay,
Yes, ma'am.
early breast carcinoma. Now how to proceed?
Next part of triple assessment is radiological assessment, ma'am. Radiologically, I would like to do an X-ray mammogram for this patient, ma'am.
Only X-ray mammography?
Usually X-ray plus sonomammogram is done for better the yield, ma'am.
What was her BMI or breast cup size?
Her BMI was 25, ma'am. Breast cup size I have not evaluated.
Okay, so was it a dense breast? Because when we want a sonography to supplement with a mammography, she is 52 years. She is
It's
not
not
a very old
necessary
lady.
in this patient, ma'am.
So why are you going in for only X-ray mammography, not a sonomammography? X-ray mammography with complementary sonography.
Yes, ma'am.
Wouldn't that be a better one?
It will be a better one, ma'am, because sonomammography is also a good indicator of the axillary nodal status, ma'am.
So what is the advantage of combining the sonography with the X-ray mammography?
So, ma'am, assessment of the axilla is one, ma'am.
And
No, regarding the lump. The question is regarding the lump. Axilla is a separate issue. Which type of lump is better delineated by the sonography?
Benign lumps are better picked up by, I'm not sure.
No. Then why you will go for mammography, screening mammography in all women over the age of 40 years roughly? Cystic lumps, cystic breast lumps are better delineated, better identified by the sonomammogram.
Complex cyst may also present in with 4 into 3 centimeters.
Yes.
So we should do a sonography along with the X-ray mammography. So what are the findings you find in X-ray mammography?
For this patient, we found a 4x3 set of 4 cross 3.1 cross 2.9 centimeter heterogeneously hypoechoic mass with a posterior acoustic enhancement and peripheral vascularity in the upper inner quadrant of the right breast. On atypical part of this was there was no calcification that was noted anywhere in this breast lump.
What are the findings you see in X-ray mammography? Peripheral vascularity is not seen in X-ray mammography. So what are the findings you see in normally CA breast? If a patient of CA breast comes, the X-ray, what are the peculiarities you find?
Architectural distortions. There is the micro or macro calcifications. The echogenicity of the mass that is by sonography.
Okay, more important. How is the mass? Speculated with a star shape. So the margins, they will be infiltrating along the ligaments of Cooper, no? Yes. So you will find a speculated margin and distortion of architecture.
What is the size of microcalcification? Or you divide it into micro and microcalcifications?
Then 0.2 millimeter microcalcification.
0.5 millimeter is the micro. And so where do you get the macrocalcifications? What does it imply if you get a macrocalcification?
In long-standing breast lumps that have undergone benign lumps, as a secondary change, we can get a macrocalcification.
Okay. So after radiology, the third part of the assessment is
third part of the assessment is a tissue diagnosis, sir. So for this patient, we proceeded with a core needle biopsy, which yielded a result of an invasive carcinoma breast of no specific type. Immunohistochemistry was triple negative in nature, sir.
Okay. What are the other methods of
FNAC and core needle biopsy? The FNAC and core needle biopsy are the two principal methods of tissue diagnosis, sir.
Why didn't you go for FNAC?
The lump was a larger lump which needed, so when you're suspecting a carcinoma, it's always better to do a core needle biopsy due to the other information that you can gain from it. First, we can learn of the grading of the tumor as well as importantly the immunohistochemistry that can be established in a core needle biopsy. And lastly, the invasive component as well can be established.
This is the gold standard treatment.
Yes.
Yeah. For females above 40 years and the females where you are suspecting a breast lump malignancy, true cut or core needle biopsy is the investigation of choice, first investigation as compared to FNAC, right? So what can be even more better than this core needle biopsy?
An excision biopsy will be a...
No, excision is an invasive procedure.
Will you like to add something to your core needle biopsy?
Yes. Madam has given you the hint.
Image guided, isn't it? Would you like an image guided? Will you help it better? If you add sonographic, you do a lump.
Clinically evident lump, we do not require an image guidance.
No, actually image guided is better always, because you get the sample from the designated area or the representative area. Okay.
One thing. Second, another method is vacuum assisted core needle biopsy. That is even right. So what is the advantage in vacuum assisted core needle biopsy?
The representative sample can be taken, sir.
Yeah, more representative sample can be taken, right? That is the advantage. And in the small lesions, like in situ lesions, you can have the whole lesion. Yeah, you don't have to go for the excision biopsy. You can take away the whole lesion, and the local anesthesia can be given, and you can even apply the clip there for the, if you want, the patient may go for the neoadjuvant chemotherapy. So these are the advantage of the vacuum assisted core needle biopsy.
Yes.
So in sonography also the axilla was negative?
Sonographically the axilla was negative.
Okay. So now how will you are so still your diagnosis after sonography, sonomammography, after triple assessment, it is
carcinoma breast of the right side.
May I ask a question, please? Aditi, suppose there was a lymph node, axillary lymph node on the opposite side.
Yes, sir.
Opposite axilla.
Yes, sir.
What would your investigative pattern be? What would you be thinking of?
Usually an opposite axillary node constitutes the metastatic disease, sir. However, since it's a
how would it reach the opposite axilla by metastasis?
Lymphatic spread, sir. Through the internal mammary chain, it will reach on the opposite side, sir.
No. It doesn't go through the internal mammary. It could be metastasis one, but it goes through the skin mets.
Skin, okay, sir.
Okay. Secondly, what would be the other cause for a lymph node in the opposite axilla? Microtumors in the other breast.
Okay, sir.
Tumors in the other breast which are not been picked up.
Yes, sir.
Yes. Please, ma'am, please.
So what is your diagnosis after your triple assessment?
The diagnosis is a right-sided invasive breast carcinoma of triple negative variant.
In which quadrant is this lesion? In which quadrant?
Inner quadrant, sir.
Huh?
Upper inner quadrant, sir.
So tell me, out of the 4 quadrants, which are the dangerous quadrants for carcinoma breast and the favorable quadrant for carcinoma breast? And the incidence of carcinoma in which quadrant?
Central quadrant is dangerous, sir. As well as
what is the incidence?
Incidence, I don't know, sir.
Oh, you should know, na? In theory, when you are writing, the best way to communicate to your examiner is draw the diagram, make the quadrants, and write down the percentage. You get gold medal. Do you follow? So examiner doesn't have to read so many pages. So we are asking you in viva. So one is central quadrant. What are the other quadrants?
For bad prognosis, upper inner quadrant is a pretty rarely involved quadrant, sir.
So only one bad quadrant, upper inner.
Dangerous quadrants.
Dangerous quadrants, plural.
Upper outer quadrant is also dangerous.
Upper outer is not dangerous. In fact, it is the most favorable and the highest incidence, as the nature would have it. Commonest carcinoma occurring in the quadrant is upper outer, and which is not dangerous. Fortunately so. So which are the dangerous quadrants? One you mentioned is correct. Upper inner, that is where your patient belongs. Any other?
Central behind the nickelareolar complex, sir.
Even more dangerous than that.
Lower inner quadrant.
Lower inner. Lower inner and upper inner. Both the inner quadrants, the medial quadrants are dangerous. That is why sir asked you a question that the opposite axilla can be involved. So there is one of the routes which is mentioned in the lymphatic drainage of breast. Do you follow?
Yes.
So why are these medial quadrants dangerous? Why is the upper medial quadrant dangerous and why is the lower medial quadrant dangerous?
Because they will be spread to the lymphatics on the internal mammary chain as well as to the contralateral axilla, sir.
Spread
This,
to where?
combination.
Spread to where and how?
The contralateral axilla, sir.
It can spread to the opposite side.
Opposite breast and axilla.
And there is a communicating channel of the internal mammary located.
Yes, sir.
What is the danger part in the lower inner quadrant?
The spread to the liver, sir, and transcelomic spread to the abdomen.
Transcelomic, yes, transcelomic. You can have spread to the ovary.
Ovaries.
Okay. Now, as a MS level question. Okay. Lymphatic drainage of the breast.
Yes, sir.
Tell me where all the lymphatics spread in carcinoma of the breast.
So the breast is
Common as
drained,
75%.
through the 75% to the axilla, sir.
Very good.
20% to the internal mammary chain, sir. Then supraclavicular.
Then supraclavicular. Then
And
internal
internal
mammary.
mammary.
From internal mammary, where does it spread?
Internal mammary can.
It can enter, the lymphatics enter the thoracic cavity through the perforating
Mediastinal
vessels.
nodes and.
So from the
paratracheal.
perforating vessels, when it enters the thoracic cavity, some amount comes anteriorly, internal mammary, and some amount goes to the posterior intercostal.
Yes.
You know why I'm saying that? Because in the history of surgery of carcinoma breast, there was a time when people used to do ultra radical operations.
Yes.
Yet one station of lymph node was never explored, and that was the posterior intercostal.
Posterior intercostal.
Yeah. From that era, today we are in an era of the pendulum has swung from radical to conservative, to conservative, to conservative, to conservative.
Yes.
Tell me why so?
Because
Why
we
so?
are,
Why?
firstly, we
Why
are
we
picking
have
up the
reached
lesions.
why we have reached the stage of breast conserving surgery? Imagine.
Firstly, we are picking up lesions at sooner, the earlier stage, sir. Secondly, we have advanced
Aditi,
adjuvant.
sorry, Aditi, we are not picking up lesions at earlier stage. In India, most of the stages come at after 2B. So that's not the answer.
Okay, sir.
There is a change, Aditi, there is a change in a concept, the question which sir is asking. From a Halstedian concept of breast malignancy to
More cosmetic approaches, sir.
No. You will not compromise the
Oncoplastic
life of the
surgeries.
patient for cosmesis.
5-year survival remains same. You can't compromise on the cure.
Yes, sir. The adjuvant treatments are better now, sir. We have more advanced chemo and radiotherapy treatments available now, sir.
That is right, but there is a change in the concept also. That's why the concept of radical surgeries in breast has gone. You know the Fisher's hypothesis?
It's
What is
not a
Fisher's
local
hypothesis?
disease, sir.
Yeah, so that was the concept given by the Fisher first time during his project which he did, and he challenged the Halstedian principle of radical surgeries. And then came the era of new adjuvant chemotherapies, right? So breast as a carcinoma as a pathology is considered to be a systemic disease, that hypothesis says. That by the time you diagnose a small lump, the cells have already spread to the different parts of the body. So you have to control that first. Just simply excising the big areas of the breast or adjoining tissues will not give you the recurrence-free survival of the patient, right? So that is a major change in the treatment of the
Aditi,
breast surgery.
so may I ask a question? Aditi, how does breast malignancy metastasize to liver? How does it go to the liver? What are the ways of going to the liver?
It goes through the lymphatics present on the rectus sheath, sir. Through these lymphatics, it can spread to the liver, sir, through subdiaphragmatic nodes, sir. Additionally, there can also be hematogenous spread to the liver, but this is more commonly seen than that.
Okay, one is through the plexus on the rectus sheath,
Yes,
lymphatic plexus. Any other way?
Transcoelomic spread can also hematogenous spread.
Through lymphatics, through the diaphragm,
Diaphragmatic.
and then hematogenous is not
Very rare.
So please, Dr. Hemant, sorry, I cut you in. Sorry.
No, it's okay. Answered it. So Aditi, now what is your further plan? You got the tissue diagnosis?
Yes, sir.
Yeah, what you will like to do now?
I would like to, for this patient in our institute, we have decided this plan, sir, at the moment, to proceed with upfront modified radical mastectomy with axillary dissection due to the high grade of the disease, triple negative disease, and a strong family history in the patient. This is the plan
Why?
we have.
Do you think, why not, if I say BCS?
So
She has a very big pendulous breast.
Actually,
Do
no
you think high
contraindication.
grade? No, what do you think high grade and triple negative disease is a contraindication for BCS?
It is not, sir. It is not, sir.
Then why you are saying we are directly going for MRM?
So since it is attached to the pectorals, sir, there might be chances of high postoperative recurrence, sir. So better to get a proper clearance. Posterior clearance can be obtained far better with the mastectomy than the breast cancer.
So means you meant to say it's not an early breast cancer, it's a loco-regionally advanced breast cancer. That is your answer? Then I think neoadjuvant
based
chemotherapy.
on the staging, sir.
Yeah, then neoadjuvant chemotherapy is the answer.
In new staging, does attachment to the pectoralis fascia comes upstage the tumor?
Tumor, or, yeah.
It is not. It is not upstaging the tumor.
It is not upstaging. Yes.
So your modality won't change, but you have written one point: strong family history, possibility of BRCA gene.
Yes, ma'am.
Why?
So, why is this in favor of my plan of management, ma'am?
Yeah.
So, ma'am, these people are prone to develop multicentric diseases in future in the same breast. So, if we proceed with the breast conservative surgery, then it's likely that they might have a lesion again in the future in the breast, which might necessitate
multifocality.
Multifocal and multicentric disease.
Aditi, may I ask you a question, please?
Yes, ma'am.
What is the difference between a hereditary, a genetic, and a familial tumor?
The hereditary tumors are ones that have a strong predisposition based on genetic based on the genetic makeup of the patient, sir. Familial tumors are ones which are occurring more closer in families which have a genetic predisposition but occur more often than would be dictated by chance, sir.
And genetic?
Genetic.
You got genetic in both?
Sorry, sir?
You said genetic in both, hereditary and familial.
Yes, sir.
Okay, how are genes? How do genes? They can be inherited or they can be mutated.
Yes, sir.
Yes.
Right. So that's how you differentiate between genetic.
Can be even mutated.
Right. All genes are not inherited.
Understood, sir.
Yes. But all familial diseases are hereditary. Right?
Yeah.
But all genetic disorders may not be passed. So they may not be familial or hereditary. That is the difference between familial and genetic disease.
So now this lady has the BRCA gene. Okay, 1, 2, and all. What will you advise her family members?
So family members, first degree relatives especially, should start getting screened with they should start an annual self-test examination
Okay, Aditi, before that,
sorry.
Does everyone have a BRCA gene?
Yes, sir, but it's mutated in certain people with high. If it's mutated, then it's a high penetrance disease.
So what kind of mutation happens? That
Uh,
everyone has BRCA genes.
So tumor
But does-
suppressor gene, sir.
Right.
So there's a deletion mutation of the BRCA gene, sir.
So it fails to suppress tumor genes or repair the DNA.
Yes.
Right. So what is the difference between BRCA1 and 2?
Molecular subtype of the CA that we see in BRCA1 and 2 is different, sir. BRCA1, it's more likely, it's a more aggressive disease, which is a triple negative, usually basal type. However, in BRCA2, we tend to come across positive diseases, the ERPR positive or 2 positive diseases, sir. Luminal type of breast cancer, sir.
Anything else?
And the risk of other malignancies is also higher in BRCA2, sir. Which are the ovarian malignancy in case of males, and male breast cancer is more common in BRCA2. Prostate, pancreatic cancers are more common. Sir.
Okay. Actually, in BRCA1A, breast tumors malignancies before 50 years of age,
yes,
right? Increased incidence of breast cancer in the other breast,
yes, sir.
Right? And of course, other women in the family will also have a higher risk.
Yes, sir.
And then, of course, male breast cancers and all that. Okay. Okay.
When will you start surveillance in the family? She had an elder sister. At what age was the diagnosis of breast carcinoma?
He was also diagnosed at 50 years of age, sir.
So when should have been this patient started? Because
Ideally,
already she was elder sister, no?
Yes. She should have been started 10 years prior to the diagnosis of the first family member. So at her about 40 years of age, she should have been started to have mammographic surveillance.
So have you advised her family members?
Yes, ma'am. She has a daughter and a son. We have advised them to start surveillance.
How do you monitor them, or how do you advise them?
So annually they have to come for a checkup by the physician and undergo a
What is that known as?
6 months.
What is that known as? Examination by a clinician or a health personnel?
Expert checkup. I'm not sure of the exact
Clinical breast
clinical breast examination. And she should undergo. They should undergo mammographic surveillance, or if the age group is too young, then MRI can also be done. And also should be counseled for a genetic testing of the BRCA gene.
Aditi, sorry, ma'am. Do you know that Anjali Jolie got a bilateral mastectomy? Why did she go for it? Why do you think she went for it?
Because there are 4 modalities of treatment of the BRCA detected tumors, sir. So bilateral prophylactic mastectomy is having the least chance of recurrence. So that is why she preferred to go for that, sir.
There was something. Was there something else which was detected, and because of that she underwent bilateral mastectomy? She had lobular carcinoma, which has a strong predilection for bilateral.
Yes.
Ma'am, please.
So you are planning for a modified radical mastectomy with axillary dissection. With a N0, why would you like to stage your axilla first or directly go in for a modified radical mastectomy with axillary dissection?
I would actually like to stage the axilla first with a
How do you stage?
Sentinel lymph node biopsy can be.
How do you do it?
So there are 2 agents that need to be used. This is a combined radioisotope as well as a dye injection method. So on the day prior to the surgery, a lymphoscintigraphy is done in a nuclear medicine suite. So we inject radioisotope technetium-99 peritumorally, and using a handheld gamma camera, we can detect the hot spots on a scintigraphy scan. Then on the day of surgery, the same agent is injected peritumorally, as well as in the breast parenchyma surrounding the lesion, we inject a methylene blue or isosulfan blue dye. Following that, we place the gamma camera on the axilla and we detect the exact hot spot, and we can incise the axilla at that level and dissect to identify the node. So this node would have ideally taken up the dye that was injected peritumorally. Either the lymphatic channels would have taken it up, or the node itself would have taken up the dye. And following that, we do an in vivo the radiographic the testing for 10 seconds. Then we excise the involved axillary node and do an ex vivo testing, and then send it to frozen section.
What are the prerequisites for going in for a sentinel lymph node biopsy? Not all centers have that.
So in a node negative,
your center should have, if it is an N0, your center should have
this nuclear medicine
and
facilities, and good pathological
frozen section. Okay. So if you are in the best of situation, along what else what is the modality with which you do a sentinel lymph node biopsy? You are in the best of situation, you have everything in your hand. You have radioisotope study. Instead of methylene blue, what is the recent? Any idea?
I don't know.
Indocyanine green, have you heard about it?
Yes, ma'am.
Okay. So now you are in a normal government medical setup. You don't have radioisotope. You don't have frozen section. Then also you want to stage the axilla. What can you do?
We can do an ultrasound guided staging of the axilla. If there
you have already done it, and the patient is in an OT table. Now what can you do? To prevent lymphedema, it is a N0 clinically. By sonography, it is N0. The patient is on table.
Yes, ma'am.
So, and you don't have radioisotope in your hand. You don't have a nuclear medicine department.
Retrograde staging can be done, ma'am.
Pardon?
The retrograde, I'm not familiar with the exact term, ma'am, but we basically
it's a low anterior. Which are the it is a low anterior axillary dissection in which you can remove at least 4 lymph nodes.
Yes,
and you can give them for a frozen section if radionucleotide is not present with you. This has been advocated by Tata Memorial. So now, if suppose the axilla is negative by a 4 axilla, then also you want to do a modified radical mastectomy, or you can do with a subcutaneous mastectomy or any other more cosmetically better surgeries, because you don't want to keep any breast tissue. So are there some other modalities also which you can
proceed with? Just as the simple mastectomy, no?
Simple mastectomy, but you are doing the axillary clearance, no?
We have already
performed the N0. Would you like your patient to subject to full modified radical mastectomy? Okay, in modified radical mastectomy, which level of lymph nodes do you remove?
Level 1 and 2 of the axilla removed.
Level 1 and 2.
Routine.
And what else? What else you remove in modified radical mastectomy? What are the things you should keep remove, and what are the things you should keep?
So we remove the nipple areolar complex and appropriate amount of skin along with the entire breast tissue, and level 1 and 2 axillary nodes. The rest of the structures are preserved, and interpectoral nodes are also removed, the Rotas nodes.
What is the in axillary clearance? What is the upper limit? What is the lower? What is the medial? What is the lateral limit?
So in axillary clearance, the lower limit is
heard something like angular vein?
Angular vein. So a tributary of the axillary vein.
More specific. It's a landmark. It is an anatomical landmark. Heard something like it? What does this signify? This angular vein? Where it is present?
Lateral limit of
Okay, what are the nerves you want to preserve?
I want to preserve the medial pectoral nerve, the thoracodorsal nerve, and the long thoracic nerve of pelvis.
So how will you find where the nerves are?
So the medial pectoral nerve will be present just inferior to the axillary vein.
I think I am going too far. Have you assisted any modified radical mastectomy?
I have not.
You have assisted? Okay. So how do you
So just below the axillary vein, immediately below the axillary vein, running into the pectoralis muscle, we'll identify the medial pectoral nerve. Just on top of the chest wall, on adjacent to the serratus anterior muscle, will be the long thoracic nerve of pelvis, and the thoracodorsal bundle will be present more laterally. That corresponding to the third tributary of the axillary vein.
What are the complications?
Complications of the modified radical mastectomy. So post-operatively, patient can intraoperatively there can be vessel injury. Any perforators can be damaged. Then while performing surgery in the axilla, any of these nerves can be injured, along with vascular injury. And post-operatively, patient can develop lymphedema of the upper limb, as well as local complications related to the wound, seroma formation, hematoma formation, or flap necrosis.
I think she have answered much of us. Any other? Hemant sir?
Yeah. Dr. Aditi?
Yes, sir.
What are the contraindications for breast conserving surgery? BCS.
So
now every attempt is done to do the BCS as compared to MRI.
Yes, sir.
Until unless there are specific indications for MRI, right? Especially after the new adjuvant chemotherapy has become so popular. Now even in the early breast cancers, some centers are directly going for the upfront new adjuvant chemotherapy first, even in small lesions, right? So what are the contraindications?
There are absolute and relative contraindications.
Yeah.
An absolute contraindication is a contraindication to radiotherapy in itself, that is pregnancy. Secondly, if it is a recurrent disease, or if it's with the clearance, the margins are positive, then we cannot go ahead with
it's not a question of recurrence of the disease. We have a diagnosed case of breast carcinoma. First you said the patient is pregnant, because in the BCS you have to give local radiation, right? And that can not be given to the pregnant lady. What are the other contraindications for BCS?
So for the margin positivity is a contraindication, sir.
No, you can re-excise it. You can margin positivity after the BCS. Now you have done. You meant to say if the margin is positive, you will go for MRM then? In all the cases, why not just re-excising the margin?
Can be done, sir. And are there any active connective tissue or disease contraindications?
That is a relative contraindication if the patient is having active connective tissue disorder like SLE.
Severe pulmonary disease or severe cardiac disease.
Yeah, pulmonary disease means previous history of radiotherapy for any other cause, because radiotherapy is must after BCS. So if it is a previous history of radiotherapy to the chest region, like mental radiation for the lymphomas, then there will be further damage to the lung parenchyma.
Yes.
That is absolute contraindication. What is the other absolute contraindication for BCS, where it is not possible to do the BCS?
If there is a multifocal or a multicentric disease that cannot be excised through a single
multifocal is not a contraindication. It's a related because that can be included. Multifocal lesions. And another relative contraindication is the tumor to breast ratio. Tumor size to breast ratio. If the breast is small, because the basic concept of BCS, you should have a cosmetically acceptable breast. If the breast is small and you do the BCS and it's a distorted breast, then it is of no use.
Yes.
That is better to go for MRM, and then you can use the silicone implants or the reconstruction of the breast. Yeah? So, what are the advantages of neoadjuvant chemotherapy?
It can downstage.
Why it has become the standard of care for
can
local
downstage
regionally advanced
disease such that we can perform breast conservative surgery even for initially advanced lesions, sir.
Yes, one.
Then secondly,
the main reason is we just discussed Fisher's hypothesis. First, the systemic disease.
Systemic disease.
So let's first control the systemic spread. Let us not waste time of 3 to 4 weeks in doing the MRM, then waiting for the wound to heal and then starting. What is the another big advantage of neoadjuvant chemotherapy? That is a very big advantage.
Sometimes lesions can disappear.
Anything to do with tumor sensitivity?
Sensitivity to post-operative, if in case it will increase to the chemotherapy.
What is the advantage of giving a chemotherapy before surgery? Apart from main role is to control the systemic spread. Then there is another very second big advantage of neoadjuvant chemotherapy before the surgery. You know beforehand whether the tumor is sensitive to this chemotherapy drug or not, because if it is not responding, you have the option to change the chemotherapy drug.
Yes.
Right? But once you have done BCS or MRM, then you don't know the chemotherapy regime which you are given, whether it will be of use to the patient or not. Yes. Patient receives a full chemotherapy for 6 months and then the patient comes with recurrence because that tumor was not sensitive to that regime.
Yes,
so neoadjuvant chemotherapy gives you the opportunity of testing that. Yeah. So if it is sensitive, tumor size regressing, very good. You will continue with that in the post-operative period, like adjuvant part, right? Yes. But if it is not sensitive, you can change the drug and again see for its response. That is the biggest advantage of neoadjuvant chemotherapy, right? Yes. Apart from the BRCA, what are the other genetic syndromes which are associated with breast carcinoma?
Leaf-Romani syndrome, the P53.
Leaf-Romani syndrome. What is Leaf-Romani?
Tumor suppressor P53 gene deletion.
P53 gene. Right. What are the tumors which you get there? Other malignancies associated with the Leaf-Romani syndrome?
Not sure, sir.
No. What is SLBA syndrome? Also known as SLBA syndrome. That is sarcoma, leukemia, breast cancer, and adrenal gland tumors. So, and how many percentage of BRCA constitutes towards the total genetic breast cancers?
70%.
It constitutes only 20% of the total genetic. Other are Cowden, Leaf-Romani constitutes roughly 50% chance in Leaf-Romani also. It is a very common cause of genetic malignancy. Sporadic, and only 10% of these genetic, 90% of the sporadic breast cancers.
Yes.
Right?
Yes.
Okay. I think it's 10.
I think we can close.
Yeah.
Sir.
So
Aditi, you have done a good job.
Yeah, yeah.
Good evening. Good evening. I've been watching quietly. Thank you very much.
And now take up the front seat.
Still in the hospital only. No problem. I think normally we allow the students to ask questions. Do we have any questions, Dr. Aditi? Doubts or any comments you want to clarify?
Really, sir.
So give our kind regards to Shanti ma'am and Kannan sir for permitting you to give this case. Professor Anil and Professor Swagata ma'am, Hemant sir, do you like to give any closing comments before we move on to our faculty?
Okay,
Both the
they have
students were
present.
very good today.
Yes.
They
Thank
have
you very much.
completed the entire, right from the diagnosis to treatment management. So I
Yes,
think
ma'am.
the full basket was covered.
Thank you very much, ma'am. Anil sir?
Yes, both have done very well, and it's a very good initiative and a very good training program. Very
It's
nice.
been
Yeah.
happening for last 136 weeks, sir.
Okay.
Please,
Good.
maybe you can also permit your PGs whenever possible, sir.
Yes. Definitely.
Thank you for joining, sir. Sahai sir and Kanna sir. Kanna sir is left, I think.
Yeah, that's it.
I think both the candidates are very nice. The whole discussion was very, very informative for all of us also. And I think the candidates fared very well.
I think Anup is still with us. Anup, do you have any questions, Anup? Anup? Okay, I think he's incognito. Thank you very much. And we look
Good night.
forward for next week, next Friday, if there's a case. One case is already confirmed. We have a growth of the penis, and then we'll be most likely having another cutaneous malignancy for discussion. That makes things easier. Any candidates watching in Zoom or in the YouTube, because YouTube candidates do watch over a period of 1 week. So anybody who is interested in presenting can reach out to me. Thank you very much. Thank you, Aditi. Give our kind regards to Chief and Shanti ma'am. Swagata ma'am, Anil sir, Hemant sir, thank you very much.
Thank you. Thank you so
Ajit
much.
sir,
Thank you
thank
so
you
much.
very much.
Thank you so much.
So we call it a close with the permission of the faculty. Good night, everyone.
Right. Good night, everyone.
Right.
Thank